Dr. Reginald Holt is a tenured associate professor, clinical professional counseling program coordinator, and department chair within the Department of Counselor Education and Family Therapy at Central. He completed a PhD in counselor education at the University of Missouri St. Louis, an MA in clinical psychology at East Tennessee State University, and a 2-year postgraduate training program in advanced psychodynamic psychotherapy at the St. Louis Psychoanalytical Institute.
Well, thank you. Well, here's Jolene. I said Guy and Jolene should come today, but she hadn't been to the beauty shop in a while, and she wasn't prepared. But she definitely did stay by me for the whole time, next to the desk. But anyway, I don't know what to say now because that was all I was going to talk about, was just my background. But he already took care of it, so see you later. But yes, seriously, thank you for being here. I thought I would just, instead of trying to reinvent the wheel and wing it, since this is about my book, I figured I would just read different parts of the book, like the back cover that gives a nice introduction, the dedication. I will talk about the history of how it came to be, and then the preface, and and then that'll give you everything that you need to know about the book. And depending on the time, if we need to, Q&A, of course, I think a little bit anyway. But I can also read a little bit from chapter 1 if needed, some of the statistics that help illustrate why this population desperately needs a focus in the clinical community as a co-occurring disorder, as opposed to silos of psychiatric or mental health treated over here and then addiction treated over there. And then hopefully it all comes together. But really it needs to be together as integrated treatment. So let me just read the back here. Hopefully, and then I'm just quoting, I'm not adding to it. So this is published by Springer Publishing. Actually, 2024 is the publication date, but it was put in print spring of this year. So, the premier text on co-occurring mental and substance use disorders. Written by professional counselors for counselors, this lucid text delivers comprehensive information for those who work with individuals struggling from these complex maladies. It is distinguished by its grounding in the holistic wellness orientation of the counseling profession, and the segment is dedicated to special populations such as the military, LGBT plus community, multicultural, and those that are gender or age related across the lifespan. Authors are from diverse backgrounds, mostly of counselors, and they provide an orientation that is distinct from that of the medical community. Written for master's and doctoral level students in counselor education programs, this text provides the most current information available and is aligned with the Diagnostic and Statistical Manual as well as KCREP standards. I'll talk about that a little bit more if you're not familiar with what KCREP is. The book offers a step-by-step approach to understanding co-occurring disorder concepts, the guiding principles for working with such clients, treatment approaches, and diagnostic considerations, and the neuroscience of addiction and mental health as well. It includes a breakdown of specific co-occurring disorders and describes specific population considerations. Clinical case illustrations bring context to life, and discussion questions reinforce the information. A robust instructor's package includes an instructor manual, a test bank, and instructor chapter PowerPoints for their lectures. Adopting this book includes digital access for use on also all the mobile devices and computers as well. So there's a plug. Key features include written by professional counselors for counselors, guided in the holistic wellness orientation, the special populations, the diagnostics, different treatment considerations, case illustrations, learning objectives, discussion questions to foster critical thinking, and again, all aligned with the Diagnostic and Statistical Manual published by the American Psychiatric Association and our KCREP standards, which is basically the accrediting body for all counselor-related and educational programs. So if you're KCREP accredited, which our programs are in the department, which is the clinical mental health and the clinical rehabilitation counseling programs, that basically indicates that a student who graduates from that, no questions will be asked as far as the validity or the quality of the master's degree or doctoral degree that they obtained when they go to seek licensure. So, let me just go into the dedication here. I was trying to, people ask, why are you in addictions counseling or clinical mental health? That's a whole story, but I was thinking about it the other day, and I think Freud said, Freud said, he didn't say it to me, but supposedly he said, the dream is the fulfillment of a wish. So maybe in hindsight, consciously did I know why I was doing this back in the day as far as getting into this field? But now that I maybe have a little more insight, a little more self-reflection, I believe it's got to do with, definitely there's lots of family members in my family that have addictive disorders, and in my armchair psychologist opinion, probably some psychiatric disorders as well, but don't seem to want to do much about it. So maybe creating this book and developing it is, my desire was maybe to help them indirectly, and so therefore maybe publishing this book is the fulfillment of my wish, the dream come true. So here's the dedication that I've written. To those individuals, including family, friends, and all others who are impacted by co-occurring mental health and substance use disorders. May you retain hope when challenged by despair. May you gather courage when surrounded by fear. May you receive compassion when facing rejection. May you experience ease of suffering when feeling pain. May you maintain equanimity when enduring a storm. May you manifest resiliency when confronted by defeat. And above all, may you achieve sustained health of mind, body, and spirit while traveling on the road to recovery. So that's a general dedication. Specifically, it's dedicated to my former department chair in my doc program, my former academic advisor, as well as my former dissertation chair, Dr. Mark Pope. He was at the University of Missouri in their doctoral program, and he passed away in January of this year. He was a big deal in the field, fellow and past president of the American Counseling Association, and the list goes on and on and on as far as his publications, and a big career counseling person and LGBT and Native American advocate. So he passed away, so I wanted to, and actually I'm thinking, I don't know for sure, but we just got published in a journal last year, and I contributed to the last book he published, which came out last fall. So I'm hoping, I'm assuming, not hoping, that I was with him to the very end of contributing to his last works. So to Dr. Mark Pope, I am honored you are my mentor and my friend. Your sage wisdom and never-ending guidance gave me the courage to dream big and the confidence to achieve those dreams. May your spirit rest easy as you take your place among the stars. Oh, I don't get all emotional here. And to my mother and father who are no longer on this earthly plane, because of the loving support you provided me during my early education, your legacy lives on through this work. So I'm a first gen, and my father only went to the 6th grade, and he couldn't hardly read because I'm from East Tennessee. That doesn't mean because I'm from East Tennessee you can't read, but just give you a background. I truly grew up in southern Appalachia in the hills of East Tennessee, so mother went to 8th grade because women should not go to school beyond that. So anyway, this is for them. Okay, let that go. All right, so how did this book come to be? Well, that was kind of, I don't know if it was destiny or whatever. I did not seek it out. I got an email from Springer Publisher, one of the editors. I guess it was probably in early 2019, saying that they would be at the American Counseling Association's annual conference, which was in New Orleans that year, and that they were interested in meeting me if I was going to be there to talk about possibly doing a book. And I'm like, why me? So anyway, I met with them in March of 2019, talked to them, deliberated, talked to Dr. Pope. He's like, of course you should. But he's like, wait till you're tenured. I'm like, no, I'll do this and it'll help me get tenured. And he's like, okay, good luck, but it happened. Unfortunately, he passed before he saw it in print, but anyway. I'd originally approached him to be the co-author, co-editor with me, and he's like, I'm already working on the other book. See if somebody else is available. So that spring of 2019 and into the summer, I started looking around. So Regina Morrow, she's Dr. Regina Morrow, she's at Palo Alto University right now. It's where she works. But she's a counselor educator and also a licensed counselor and an addiction specialist, and she had already published a book on addiction counseling, which is a textbook for master's and doc programs. So, and I've met her at some of the conferences we'd went to, and we're both, I'm the secretary of the International Association of Correctional and Offender Counselors and Addiction Counselors, and she was on the board. So I approached her, and she's like, let's do it. So that was the summer. So we spent from fall of 2019 through the spring of 2020 doing a proposal. So it's misleading. We want you to do a book, says Springer. And then when I say okay, they're like, okay, you got to do a proposal, and we have to approve it, and we have to agree that we want you to. And I'm like, okay, I thought you wanted me to. So anyway, it's like bait and hook, right? So anyway, it took about half a year plus to do this proposal, this market analysis of all the co-occurring textbooks that were out there, which most of them were written by either psychiatrists, the medical community. Some were written by social work or other licensed behavioral health professionals, but none of them, and a lot of them were old and outdated, meaning the books, not the authors. And I was teaching co-occurring disorders here in our program, and the one that I used, which is a great book, but it was written by a psychiatrist. So I felt there was a gap in the publication community of this book. There's a gazillion books on theories and techniques of counseling, multicultural addiction counseling, but there's really a paucity of co-occurring disorder books, regardless of who's written it. So did all that market analysis, went back and forth. They had to send it to their peer reviews, and then we started getting, pulled through the screening process and revising the proposal. I'm like, we're ever going to get to the book, to the contract? So finally did. So the contract was signed October of 2020, and then, of course, that was right at the beginning of COVID. So now they wanted the book completely. I hope they don't watch this. They wanted the book. The contract was, this will be delivered within 11 months. And I'm like, okay, if I'm going to sign this, but am I going to go to court? Because I know it ain't going to happen in 11 months. It's just too much. Like, yeah, it could be renegotiated. So it got renegotiated a few times. But COVID, of course, threw a wrench in everyone's life. And, of course, this. But the final manuscript, it's like, I don't even know. I should know. Once I finally finished it, it was like, I put it behind me for a minute. 18 chapters, plus all the other ancillaries. That was, the final one was submitted October of 2020. So then didn't have to think about it for a while, and then it came out in print in March or April of this year. So Dr. Morrow and I have already presented it at the American Counselor Educators and Supervisor, I can't even say ACES, the American Counselor Education and Supervision, or Educators and Supervisors Conference in Denver in October. We've been nominated for the National Board of Certified Counselors Excellence in Counselor Education Creative Works or Research. So we'll see what comes of that. But that's a little bit of the background. How we doing on time here? Keep on rolling? All right. Well, I thought I'd read the introduction just to give you a little deeper dive into the book and some of the stats and what each chapter is about. And then we'll see where we are at that point. So again, this book is designed as a tool for graduate students studying to become professional counselors who work in a variety of settings, including healthcare agencies and treatment facilities. And it's also for clinicians already in the field. It's not just for students working to become counselors in training, if you will. It's highly likely that all counselors, regardless of their specialty or work environment, will encounter clients struggling with a co-occurring mental and substance use disorder. National statistics highlight this sentiment. In 2020, there were almost 53 million United States adults with a past year mental illness, over 14 million with a serious mental illness, 21 million with a past year substance use disorder, and an additional 17 million who have both mental illness and substance use disorders known as co-occurring disorders. While these numbers represent adults over the age of 18, adolescents also experience co-occurring disorder with elements of either disorder emerging throughout their adolescence and into their adulthood. Professional counselors who work with clients need to be aware of the overlap between substance use disorders and mental disorders in order to identify, intervene, and provide ethical and competent treatment. This book is also a resource for established counselors who did not receive comprehensive education while in their training program, yet find themselves working with clients who who have the diagnosis of co-occurring disorders. Unique to this book is the focus on the profession of counseling. The editors and the authors are all professional counselors, many whom are counselor educators and clinical supervisors with direct care experience working with individuals diagnosed with co-occurring disorders. Being grounded in the counseling profession offers a holistic wellness perspective that's often missed from other books written by professionals who have medical degrees or other behavioral health backgrounds. The content of this book is designed to be a straightforward yet comprehensive text that provides counselors in training and counselors in clinical practice a thorough review of co-occurring mental and substance use disorders. The text is divided into 4 main sections. The first section is called Considerations for Treating Co-occurring Disorders. So using a stepwise fashion, the text begins by creating the groundwork by introducing the concept of co-occurring disorders. In chapters 1 through 3 is where the considerations fall under. Chapter 1 offers a general overview, including the prevalence of co-occurring disorders, describes the etiological paradigms and risk factors for developing co-occurring disorders, and outlines the guiding principles for working with individuals who have co-occurring disorders as recommended by the Substance Abuse Mental Health and Service Administration, otherwise known as SAMHSA. Chapter 2, I know, we'll get there. It's like 18 chapters. He's only on 1. It's not that long. Chapter 2 provides a brief overview of addictive disorders, both substance-related and behavioral addictions. Information includes commonly abused substances of abuse, distinct models of addiction etiology, and the Diagnostic and Statistical Manual of Mental Disorders using that classification system, which is published by the American Psychiatric Association. Chapter 3 provides a comprehensive introduction to the neuroscience behind co-occurring mental and substance use disorders. Then Section 2 is specifically designed to address treatment approaches for intervening with this population. Section 2 transitions the reader to their work with future clients, including specific treatment procedures common to all counselors. This consists of chapters exploring the screening, assessment, and evaluation processes, the various levels of care in which clients may receive treatment, and useful information that clients may encounter once they enter treatment. Chapter 4 provides an overview of screening, assessment, and evaluations. The readers will gain a general overview of treatment and recovery plan developments to guide their future work with clients and their initial encounter. Chapter 5 provides details regarding the level of care options for clients. This includes managed care admission guidelines based upon medical necessity, as well as a discussion of the American Society of Addiction Medicine, otherwise known as ASAM, using ASAM's 6 dimensions of the multidimensional assessment and patient placement criteria. In addition, Chapter 5 explores community supports with this client population. Chapter 6 introduces readers to the trans-theoretical model of change and explores motivational interviewing and motivational enhancement therapy. In addition, person-centered, humanistic, and cognitive behavioral theories for treating co-occurring disorders are discussed. Relapse mechanisms, relapse prevention, and longer-term recovery maintenance are also described. Chapter 7 provides a general overview of the psychopharmacology and psychopharmacotherapy as it relates to working with people with co-occurring mental and addictive behaviors. This attends to both behavioral health psychotropic medications such as antidepressants and anxiolytics, or otherwise known as anti-anxiety medications, as well as those used in medication-assisted treatments, also known as MAT. Pharmacology like methadone and Suboxone, naltrexone. In addition, the use of psychedelics in the treatment of co-occurring disorders, I know, right? Raise the eyebrows like, what? Is briefly explored because that is an emerging field of research using medications, well, using substances as a potential medication like mushrooms, LSD, ecstasy or Molly, MDMA more formally, for the treatment of like depression, trauma, PTSD, anxiety, and of course cannabis. This section concludes with Chapter 8, which examines mindfulness as an adjunct treatment for co-occurring disorder. The main mindfulness-based therapeutic programs are described, research studies supporting mindfulness are examined, and treatment integration ideas are offered. And mindfulness is obviously, or it should be obvious, or hopefully it's obvious. Clinical mental health and addiction is my specialty areas, but mindfulness is kind of like my my special interest for most of my publications, whether it's articles or book chapters, is focused around mindfulness as a intervention for the treatment or an integrated co-treatment for various disorders, especially including trauma-informed counseling. The third section is focused on diagnostic considerations. Using the Diagnostic and Statistical Manual as a base, the following co-occurring mental and substance use disorders are explained. Depressive disorders in Chapter 9. Chapter 10 is bipolar disorders. Anxiety and obsessive compulsive disorders are covered in Chapter 11. And schizophrenia and other psychotic disorders in Chapter 12, trauma-related disorders, including PTSD in Chapter 13, and then Chapter 14 concludes with personality disorders. Each chapter includes information about the description of the co-occurring mental disorder, the prevalence rates, specific assessment considerations, and treatments unique to each of these disorders. And a clinical case illustration and discussion are included at the end of each chapter. And that's actually the whole book. Finally, Section 4 are special populations. The final part of the textbook emphasizes the multifaceted variables that must be considered when treating distinct groups who are diagnosed with co-occurring disorders. These groups include a consideration of co-occurring mental and addictive disorders as it relates to gender and across the lifespan. That's Chapter 15 and Chapter 16. Chapter 17 specifically talks about the military population, active duty, and veterans, and how co-occurring disorders are prevalent in that population. And Chapter 18 focuses on the LGBTQ plus community and the prevalence of co-occurring disorders. It's important to note that the last section attends to many cultural elements of counseling practice in relation to these specific groups. However, the book throughout its entirety, the authors intentionally provide information that is relevant for cross-cultural competent practice by all counselors. Also infused throughout the book are ethical and legal implications and clinical case illustrations and discussions. Finally, the learning tools. Each chapter is intentionally formulated with the reader's education in mind. To begin, each chapter lists the learning objectives, indicating what the reader should be able to accomplish following an in-depth review of the material. Throughout the chapter content, there is a focus on helping readers understand what it means for their work in the future as a counselor. This is particularly prevalent in case illustration and discussions where readers are exposed to a clinical situation and then see how a clinical professional counselor would handle that situation. Lastly, all chapters conclude with recommended discussion questions which are meant to intentionally help counselors in training expand upon the content of the chapters using their critical thinking skills, and if being conducted in dyads or group work, learn the art of consultation and collaboration with peers. Finally, the textbook is accompanied with teaching tools for course instructors, counselor educators, and other behavioral health professionals who adopt this. It's not just for counselor educators. PowerPoint lectures have been developed for each chapter based upon the content contained within that chapter. A test bank is provided with a combination of true, false, or multiple choice questions. In addition, each question has information related to where students can locate the correct answer. A sample syllabus is offered for how an instructor may adopt the text into a traditional 15-week academic semester. And finally, accreditation information specific to the Council for Accreditation of Counseling and Related Educational Program Standards is provided for each chapter, and that's CACREP that I referred to. The editors, me and Dr. Morrow and I, Anticipate that this publication will provide a comprehensive overview for counselors working with individuals who have co-occurring mental and addictive disorders, which in turn will help those counselors become more competent in this much needed area of specialization. So I'll stop there. How are we? Good. All right, good. All right.
So let's open to questions.
And then I'm going to read all the chapters, so get some popcorn, sit back.
You're not going to sell any books if you do that.
All right.
Okay, so needless to say, I have no expertise or knowledge about this at all, but my gut is, wouldn't it be easier to try and treat one thing and then the other?
Well, that's been the historic way of doing it.
And why isn't that the smart way?
Because historically, people would think, well, if you have a mental disorder and you're, let's say, just drinking, that if you stop drinking, it'll take, if you treat the depression, you won't drink anymore. But it becomes its own entity. It becomes its own diagnosis. It becomes its own problem. So is it the chicken or the egg? There's no really one way of knowing it. There's too many factors involved. Not to say that some people may misuse substance if they have a mental disorder. Maybe take a couple shots or a couple hits of marijuana to ease the anxiety. And maybe for those, if you treat the anxiety, they may not use that to help them alleviate those symptoms. But after a while, and depending on other variables we don't have time for, if a person truly develops a co-occurring disorder, you can't treat them separately because they affect each other. Now, that doesn't mean that different stages of treatment might come in, I hate to say the word silos, but for example, if a person truly has a co-occurring disorder and they need withdrawal, or they're in withdrawal and they need medical-based detox, safety comes first. So they have to be detoxed before you can even start addressing the depression, or vice versa. If they're actively suicidal and need inpatient stabilization, you can't worry about, well, you need to go to AA, right? That comes later. But it really needs to be an integrated approach. And it's not just integrating the treatment of, and research shows that integrated approach is the best way, as opposed to mental health treatment over here, and then go over there when you're done with mental health and get your addiction treated, and then go over there and take care of your physical medical concerns. It doesn't allow for care coordination, and of course every agency cannot treat everything under their roof, but the best options when you can get it is to have a fully integrated medical, behavioral, substance use facility that can treat everything under that roof and just travel through the different care continuum depending on where the person is.
Okay, but especially the American medical geopolitical context, how easy or how impossible is having that seamless integrated care?
I think what's more challenging is to find organizations that offer all that under one umbrella. And it's not a judgment on anyone, but it is standard practice that medical should coordinate with behavioral should coordinate. If you're in treatment at this agency for a higher level of care like partial, and you've got an established outpatient counselor and an established outpatient, whether it's a psychiatrist or a primary care physician, it's expected that you collaborate and consult so that everybody knows on the same page, and that's standard. So that's not, it takes a lot of work, it takes a lot of coordination, it takes a lot of effort, reaching out and sharing and getting information, but it's not a challenge to convince people that this is the way it needs to be. Even primary cares now have to do what's called SBIRT, which is screening, brief intervention, and referral to treatment, because most people go to their primary care, right? Even if they're not going for a mental, most people, if you have access to one, you have a primary care physician that you see. And if you have mental concerns or like maybe some depression or anxiety, that's the person you're probably going to go to, as opposed to just picking up the phone and randomly calling someone in the community. It's like, can I come in? So the primary care settings are now required and expected to do, when I just did my physical last month, and they're like, have you had difficulty sleeping? Have you had thoughts of hurting yourself? Have you been down or depressed or hopeless or helpless? So those are all standard screenings that we all have to do, but they're also expected to ask about substance use. And then those brief screening intervention questions, or those brief screening questions are designed to red flag a person who may be at risk of substance use or already using or at risk of a disorder, and then that helps the primary care setting to get the person referred to or recommended to go see a specialist who can do a more in-depth assessment and then recommend treatment. Yeah.
Do you think like the stigma associated with addiction and also mental health has like helped to perpetuate like this, and not like personality disorders not going diagnosed? Right.
Well, that's part of the screening. People are not likely to admit, and you probably know some people, when you go to the doctor, like, how many drinks do you have a week? 2, and they're probably like minimizing it. Not saying that person has a substance use disorder, but people tend to minimize because of that stigma or that fear of being rejected. But then you look at certain genders or certain cultural groups, they are further stigmatized, and fear, especially women, a fear of single mothers. If I tell the doctor that I'm struggling, whether it's mental health or addiction or both, they're going to take away my kid. They're going to call family services, and then, or people with a correctional history. If they admit what's going on or even trying to seek help, they're feared that there'll be repercussions. You're going to call my probation officer. You're going to tell them this, that, or the other. So the stigma definitely does perpetuate the inability to access the treatment that's needed out of fear or being considered crazy. And again, some cultures, stigmatize it as well, not to point fingers or to judge that, but it's just part of the considerations that have to be made of, you might have a client who wants to get help, but their family just doesn't support it because we keep this private, and you need to, figure out a way to fix it or solve it, pray it away, for some cultures or some religious beliefs. And again, that's not judging, it's just the way that it is, and that's some of the challenges to working with the population, looking at those. Afraid they'll be hospitalized,
I've heard that a lot, like in the homeless community, like they don't want to seek treatment, or because then they could get arrested or be punished in some way.
Right.
And mental health and addiction is a big.
Right. Well, when you think about what's called the social determinants of mental health, you have to look at not just the symptoms and the genetics and the family history, but you're looking at what's going on in the community, if you will, that's contributing to that person's mental concerns. So it could be homelessness, food insecurity, cultural impacts, gender, finances, healthcare access. So all those things have to be looked at. It's a lot. That's why it's the comprehensive approach that you pointed out earlier before we were taping.
So does divorce have a large effect on these disorders?
You'll have to get the book and read. No. Divorce. Well, I think any stressor in life that's not welcomed. Stress can be good or bad. Getting a new job, moving to a different home that you want, having a child, getting married. Those are stressors, but they're typically eustress, good stress. It's the changes in life that we don't want that we consider to be the bad stress. So anytime there's a loss or a transition that's considered unpleasant or not wanted, that can lead anybody to experience challenges in their mental composure, if you will, their mental stability, and definitely can look at using substances to alleviate some of that stress. And that's where it can turn into an addiction. Not everybody who abuses is going to become addicted. And it's like, well, why are those? My brother is struggling right now. Not right now, he's been struggling, but right now he's continuing to struggle. I'll spare you the details of that. Why does he have the severity that he has and I don't? It's the same family, the same genetics, the same parents. They weren't divorced. You know, we grew up in the same house, not at the same time, but, you know, but that's the other thing. It's like, who knows? Is it nature, nurture? Is it genetics, epigenetics? Is it learning? Is it conditioning? And of course, our parents were different. Even though they were the same parents, when he was born in 1958, or 55, sorry, my mother was in her 20s. When I was born in the 70s, she was almost 50. So she was different in her lifespan at that point. So even though they're the same, we were raised probably a little bit differently. And I do blame him for me not being able to do anything as a teenager, because he ruined my chances. Like, he came out in full blaze of glory, and I was a shrinking violet in the home. So I wasn't a shrinking violet, but I was limited in what I'm doing. So, you know, not getting into that too much, but yeah, there's no rhyme or reason of why some people have it, why some people may be considered more resilient, and some people may be more vulnerable. But the bottom line is, treatment is available, hopefully. I say that with a little looseness, because not everybody has access to health care and resources. And for those that do, maybe the stigma does prevent them from taking that first step. And there's the good news for our students coming out, there's a lot of jobs out there. The bad news for the clients who need the treatment is there's not enough counselors right now to get them they're on a waiting list. And especially when you're looking at like opioid use disorder, where you typically don't necessarily need inpatient detox if you don't have any other considerations that may make you at risk for needing. So then it's like, well, waiting for that waiting list to get to your name so that you can get some medication-assisted treatment. And that's what keeps people locked in, you know, to using the drug. It's like, I can't deal with this without something, and I'm going to have to go back to what I know works, even though it's harmful to me. So there's a lot of barriers. There's hope, but there's still problems to work through.
Okay.
What about the differences between like the outpatient care versus live-in? So if you have, say if you have an addiction and it's occurring, but you're not necessarily someone that that drinks every day or whatever, so you don't have to like dry out. Like, it seems like the live-in centers only want you if you need to have that dry.
Yeah. So are you referring to like residential treatment,
Yeah.
or sober living houses? Which was formerly known as halfway house, residential. Yeah. So you know, there's a chapter in the book that talks about that. No, I'm not saying read it. Well, yes, read it, but I'm not deferring you to that. I'll answer your question briefly. You know, it's not just managed care that inform what level of care the person needs. It's really based upon medical criteria. So the continuum of care across the services that are offered start from, and ASAM has this, the American Society of Addiction Medicine, and facilities that are getting funding have to use the ASAM criteria. So it's all the way from 0.5, which is early intervention, from 1 to 4. I won't get into all the little minutia there, but it's from early intervention to traditional outpatient, which is usually individual or group, to IOP and partial, which is day treatment, ranging from 3 hours a day to 6, three or more days a week, and then going up to residential, and then going up to medically managed inpatient detox. And detox is just there to exactly what it's saying, detox the person safely from and detox is not recovery. Detox is just a very necessary intervention, because if you can't commit to engaging in treatment if you're in withdrawal. But once you get detoxed, if you need it, not everybody needs it. Only alcohol and benzodiazepines can be a life-threatening withdrawal, but not everybody is in that category. But those are the two main substances that could cause that. But going back to your question, it really is based upon medical necessity. So as far as how managed care looks at it, as well as even the medical community and even our community, the treatment plan has to match the symptoms. And it also has to look at, can you be treated in the most least restrictive level of care? So it's like, think about if you're, I say this in class, and now that I have to say it, I can't think about it. Think about if you needed your tooth pulled, and your dentist is like, we have to admit you to the hospital. Well, that wouldn't make sense to us. It's just pulling a tooth, right? You go in, you get it pulled, and you leave. Mental and addictive disorders have to be looked at the same way. And I get why people and families and support systems want people to be in the most restrictive level of care because of the chaos that these disorders are causing their life. But if a person's never attempted a certain level of care, they're not going to put them in a higher level of care until, which unfortunately sometimes is, you have to show that that level of care that they just need to try is not intensive enough, and then you have to work your way up. So that's the continuum of care. Residential treatment for managed care, at least, is not designed to be residential in the sense of just housing. And I know that some families get to the point of like, just keep them. They're not going to live here, and we're not going to take care of them. We're kicking them out. And we've tired. You deal with them. But if the person, but it's not meant to be custodial housing only. So, but bottom line, to answer your question, it's based upon the medical necessity, the current symptomatology. Have they demonstrated an inability to get the treatment they need at a lower level of care? And then they work in and out, up and down through the community. You can be in partial and then maybe go back to actively drinking and have to go back into detox, and then maybe go back to partial and then step down to IOP and into outpatient, and then if you relapse and more problems come. And again, the co-occurring disorders is what makes it very complex. You've got, and you can have multiple co-occurring disorders. You can have alcohol use disorder, you can have opioid use disorder, you can have major depressive disorder, you can have PTSD, all those combined. So now can you imagine the complexity of the clinical picture? And you get people who are maybe not as qualified to acknowledge the differences and to see the individual nuances of each disorder and how they overlap and how they integrate and how they're still their own thing. So that's hopefully what this book does, is to help people see all the various. It's not just simple as mental health's over here, addiction's over there, and if you have a co-occurring disorder, you've only got depression and you drink. Maybe for some that's that way, but there's a combination of everything, and it really throws a wrench in a lot of the treatment and the resources out there. And for the clients too, right?
All right, 30 seconds. Define mindfulness for us.
God. 30 seconds. Mindfulness. It's in the book. No. It's the ability to accept what is in this moment, regardless of what's happening, taking it moment by moment without judging it, allowing and letting be, not pushing away things you don't want, and not seeking pleasure to feel better for things that you wish weren't here.
There you go. All right, that's how we'll end this. All right, thank you very much.
Thank you. Thank you, thank you, thank you. Available at the bookstore, on Amazon, and through Springer Publishing.
Thank you.